Let us now begin the discussion of birth asphyxia and HIE. Birth asphyxia is synonymously used with perinatal asphyxia. HIE is hypoxic ischemic encephalopathy. Before we discuss the topic, we need to understand a few terminologies. Now you know that we have talked about neonatal resuscitation. If the neonatal resuscitation is not successful, or if there is prolonged hypoxia, the child is not breathing well, there will be ischemic damage to the brain and various internal organs. That spectrum of disorders is called as perinatal asphyxia, and the clinical state arising from that involving brain is called as hypoxic ischemic encephalopathy. It's a complete topic in itself, and a lot of new developments have happened, and so can be asked in entrance exam. So as I said, what are these terms? What are their meanings? They are very often asked, but people often get confused between them. So before we discuss the topic itself, there are a few terminology or terms that you need to understand. They are very important. So first of all is, what do we mean by hypoxemia? Emia means in the blood. So hypoxemia is decreased arterial concentration of oxygen. So when saturation in the blood is low, we call it as hypoxemia. What is hypoxia? Hypoxia refers to, clinically it refers to decreased oxygenation at the level of cells or tissues or organs. So blood में less oxygen is hypoxemia, and decreased oxygenation at the level of cells or tissues is called as hypoxia. What is ischemia? Ischemia refers to perfusion, right? So poor perfusion or inadequate perfusion to meet the metabolic needs of the body. Perfusion which is not sufficient to meet the metabolic needs of the body, that is called as ischemia. And fourth is asphyxia. Asphyxia is related to breathing efforts. So whenever there is hypoxia due to poor or absent breathing efforts, we call it as asphyxia. And finally we have HIE. HIE stands for hypoxic ischemic encephalopathy. So it is a CNS state, altered sensorium state, mental state, which is produced due to hypoxia and or ischemia. So CNS state, the clinical state produced because of hypoxia or ischemia, is called as hypoxic ischemic encephalopathy. So the meaning of these terms are important, and obviously when we read the topic, what happens sometimes is we just simply jump into the criteria, diagnosis. We don't understand what is the meaning of that. You understand the meaning, things make more sense. So that now we have talked about these terminology. Let us first talk about how do we define, what are the criteria to define perinatal asphyxia. So the first thing we'll be discussing is essential criteria to define perinatal asphyxia, also called as birth asphyxia. There are 4 essential criteria which must be present for asphyxia to happen. The first criteria says, whenever a child is born, you take out umbilical artery blood and send it for ABG analysis. If it shows acidosis, that is one of the criteria positive. So umbilical artery blood showing acidosis. What is the objective criteria in this? The pH of this umbilical artery blood should be less than 7.0. That is first criteria which is positive. The second criteria is a low APGAR score. We have already talked about APGAR score when we discussed the neonatal resuscitation. So low APGAR score, that is 0 to 3 for more than 5 minutes after birth, is again a criteria for perinatal asphyxia. Third, the child should have a neurological manifestation. Any neurological manifestation, like there should be seizures, or there should be coma, or there should be decreased tone, that is hypotonia, or any other manifestation of HIE, that is just vague altered sensorium in the child, poor feeding, that kind of a issue. So any neurological feature should be present. And fourth feature, other than neurological manifestation, at least one organ system should be involved. So the fourth criteria says evidence of multi-organ dysfunction. You will say multi-organ dysfunction when other than the CNS, one more system at least is involved. Multi-organ dysfunction can be in the form of any of the following. Either there can be kidney involvement producing acute tubular necrosis, which is very common, or there can be cardiac involvement producing myocardial depression, or there can be asphyxial lung injury. In addition, there any multi-organ dysfunction due to asphyxia. For example, subcutaneous fat may show subcutaneous fat necrosis. So any of the organ system other than CNS, if it is involved, we say the fourth criteria is fulfilled. So these are the four criteria how we define perinatal asphyxia. After defining these criteria, let us move our attention towards the neuropathology of HIE. Neuropathology of asphyxia. Neuropathology means what are the pathological lesions being produced in the brain. We know that neurons are very sensitive to hypoxia, but the type of neurons which undergo damage, they vary across term and preterm babies. So we will form two categories here. On one side we will write the term babies, other side we would write the preterm babies. In term babies, first of all, the first thing that happens is a group of lesion called as selective cortical neuronal necrosis. So there is necrosis, ischemic necrosis of the cortical neurons, right? And these cortical neurons, we call it as selective because specific group of neurons are affected. Most commonly, it involves neurons present in the cerebral cortex, in the hippocampus, and in the anterior horn of spinal cord. They are very commonly affected. That is the first lesion which is seen in term babies with HIE. The second group of features we see in these babies is called as parasagittal injury. Parasagittal areas are the watershed areas where overlap between the arterial systems, the anterior, middle and posterior cerebral arteries is inadequate, and whenever damage happens or hypoxic damage happens, these are the sites where infarcts tend to develop. So parasagittal injury can produce parasagittal infarcts. These parasagittal infarcts, potential MCQ, can later in life lead to a condition called as spastic quadriparesis. So all the four limbs getting involved is quadriparesis. So spastic quadriparesis or spastic quadriplegic cerebral palsy can develop in those children who develop parasagittal injury. So this can be asked as a potential MCQ for your exam. Okay, which spastic quadriparesis develops due to which type of injury? Term baby is developing parasagittal injury, right? The third thing, the third lesion we find in the brain is called as status marmoratus. Status marmoratus is actually a clinical state which correlates with injury involving the basal ganglia and thalamus. So, whenever there is necrosis of the neurons, particularly affecting the basal ganglia and thalamus, it can produce an altered sensorium comprised of features like chorioathetoid movements or chorioathetosis. The patient can have mental retardation and there can be spastic quadriparesis features. So you can simply write as movement disorders. So movement disorders will be there. This whole clinical state is called as status marmoratus. Very important point, status marmoratus, the brain tends to show a marbled appearance. Marbled appearance is seen in which lesion? It is seen in status marmoratus, right? And fourth feature which is seen in these children is focal ischemic necrosis. Focal ischemic necrosis later in life can progress to produce a condition called as spastic hemiparesis. Spastic hemiparesis. So these are the 4 types of lesions that we find in term babies who undergo asphyxia. On the other hand, preterm babies have a different set of neurons which are getting affected. First of all, preterm babies, they tend to develop not cortical, they tend to develop subcortical neuronal necrosis. So subcortical neuronal necrosis means the subcortical structures are affected, particularly the lesions tend to occur in diencephalon and pontine nuclei. Second feature, which is also considered to be the hallmark of ischemic damage in preterm babies. The hallmark of ischemic damage in preterm babies is a group of condition called as PVL. PVL stands for periventricular leukomalacia. It is a tongue twister word, but very simple to understand. There are ventricles in the brain, so periventricular will mean around the ventricles. Leuco means white matter and malacia means damage. So damage to white matter only around the ventricles of the brain is called as periventricular leukomalacia. Periventricular leukomalacia increases the risk of developing spastic diplegia in later life. In diplegia, lower limbs are more severely affected than upper limbs. Spasticity, it is a type of cerebral palsy. All these things we have discussed in cerebral palsy. So periventricular leukomalacia is the hallmark condition, MCQ point. And thirdly, you will find a lesion called as periventricular hemorrhagic infarction. Periventricular hemorrhage can happen along with infarction. This can be one of the features seen in preterm babies. So this is the spectrum of neurological states which are produced. When you are reading from your books, you often tend to oversee these things, but questions are indeed asked from them. And as you can understand, if you have not read them in this way, it will be difficult for you to remember. So do them, and there is a clinical correlate also which can be asked in visuals. Let us have a look at the visuals. Look at these 2 neuroimaging findings. In the first picture, look at this one. They can show you this picture that this is imaging done in a child who underwent hypoxic ischemic damage. Tell the type of lesion and the probable gestational age. How are you going to do that? Very simple. First of all, they have given a clue that there is ischemia in the patient, right? So look at these lesions. This is the area where basal ganglia and thalamus are present. So this is the area where lesions are present. So can you see that bilaterally basal ganglia and thalamus are affected? So this is a classical lesion of status marmoratus which is being shown here. And status marmoratus tends to occur commonly in term babies. So your answer will be, it is basal ganglia and thalamic involvement producing status marmoratus. What is the gestational age? Term babies, right? Look at this, the other picture. Can you see that these are the ventricles, and around the ventricles there is extensive white matter damage. So these opacities around the ventricles is indicating development of periventricular leukomalacia, and periventricular leukomalacia will always occur in a preterm newborns. That is how theoretic eye sees what the mind knows. So if your mind knows these are the things, if you get a picture like this, you can easily reach the correct answer even if you have not read these findings in details in radiology. So this is how visuals need to be correlated with whatever text you are reading. Let us move our attention now to clinical staging of HIE. Clinical staging, now there are 2 types of staging systems which are followed. One is 11A staging system which is now discarded. It is no longer used. It is mentioned in OPGAI, but no questions are asked from that because clinically we don't use it. What we use it is the Sarnath and Sarnath stage. This is the staging system which is mentioned in Nelson also, and MCQs in AIIMS entrance and NEET PG exam have been asked on Sarnath and Sarnath staging system of HIE. So we need to remember this staging system. Let us write down. On one side, you would write the parameter or the sign. In the middle, you will write stage 1, stage 2 and stage 3. Earlier they were called as mild, moderate, severe. Now they have been renamed as stage 1, stage 2, stage 3. First is level of consciousness. In stage 1, the child is hyper alert. Now a lot of people ask, sir, what is hyper alert? Hyper alert does not mean the child has some superpower now. So hyper alert simply means a irritable child. He is over responsive to the external stimulus. Stage 2, the child will become lethargic. Stage 3, the child will become comatose or unconscious. Stupor is also a feature of stage 2. Second, we have muscle tone. In stage 1, it will be normal. In stage 2, it will be decreased, so some hypotonia will be seen, and complete flaccidity, tone is entirely gone, will be seen in stage 3. Then we have posture of the child. In stage 1, the posture will be normal. In stage 2, there will be some flexion being shown, and stage 3 will show decerebrate posturing. Then we come to deep tendon reflexes or clonus activity. In stage 1, the deep tendon reflexes are hyperactive or brisk. Stage 2, again same, hyperactive or brisk. Stage 3, they are absent, so tend to disappear in stage 3. Myoclonus. When you check for myoclonus, it is present, absent. Morose reflex. It is strong, it is weak, it is absent. We look at the pupils. Mydriasis is seen in stage 1. I hope you know what is mydriasis. Meiosis and unequal pupils or fixed pupils will be seen in stage 3. Then seizures. Seizures are very common. There was an MCQ asked in entrance exam where the diagnosis could easily be made based upon the seizure status. Seizures are absent, very frequent, they are rare to absent. Rare to absent, right? Then we have EEG abnormalities. In stage 1, you will find a normal EEG. So no abnormality will be seen. Stage 2, there will be low voltage activity, or if the seizure is present, there will be seizure activity. Whatever seizure pattern, that will be seen. In case of stage 3, very important potential MCQ, you will find a pattern called as burst suppression pattern. Burst suppression pattern is seen in stage 3. What is burst suppression pattern? Initially, there will be a burst of intense activity, then it will be suppressed for some time, then burst, then again suppressed, then again burst. The entire EEG reading will look like this. This is called as burst suppression pattern. You get a visual like this, the likely diagnosis is stage 3 HIE. Or rarely, you may find a pattern called as isoelectric EEG. Isoelectric EEG will be a flat line. So no activity, it is almost like a brainstem death in the patient. Moving to duration. Stage 1, the patient usually lasts for less than 24 hours. Stage 2, it lasts from 24 hours to 2 weeks, that is 14 days. And stage 3 may last for days to weeks, even months it can persist. Then what is the outcome? It is good, it is variable, it is poor. In stage 1, we find that more than 95% patients tend to improve. Although there may be some damage which may be left behind, it will vary from child to child depending upon what specific group of neurons are affected and how much they are affected. Stage 2, you will find that more than 80% will improve, but even in those improving, they may be having some residual deficits. Stage 3, around 50% will die. Remaining 50% will be left with severe neurological sequelae. So the outcome in stage 3 is not good. So this is regarding the staging system of Sarnath and Sarnath. Looks a bit complicated. If you are in a hurry, what are the areas you should focus upon before you sit for your exam? Look at pupils which are asked, look at seizures which is asked, look at EEG which is asked, look at level of consciousness, and look at Moro's reflex. These are the things which are very frequently asked in MCQs. Ideally, whole table is to be done, right? But this is only for, see, I always believe you should always have a plan B. Plan A is reading everything, being ready throughout, always works best. Emergency happens, something wrong happens, plan B. What are the bare minimum things you should do? So whenever you do anything in life, whether it is related to academics or it is related to some business, some investment, anything, always have a plan B. Moving over to the next thing, that is investigations in HIE. Do not have your plan B in case of your personal relationships. That is wrong. So investigations, the investigation of choice in HIE is MRI brain. So investigation of choice is MRI brain. There are many types of MRI images. There is a T1 weighted image, T2 weighted image, FLAIR image, and diffusion weighted image. So it is the diffusion weighted images which are considered to be the best. So diffusion weighted images are the best. In case of hypoxic ischemic encephalopathy, HIE patients, you will find a restricted diffusion which will appear as increased signal intensity. That will tell you the development of the areas involved in HIE. Additional investigations. There is a new investigation which is being done these days. We call it as AEEG. AEEG stands for Amplitude Integrated Electroencephalogram. Amplitude integrated EEG is useful to determine, it is useful to monitor the infants with HIE and to identify those with increased risk of permanent neonatal injury later in life. So it is useful in monitoring and risk assessment in the newborn. However, despite this being a EEG, its sensitivity is less than 50% for seizures in HIE. And so, for seizure activity monitoring, you should only do a conventional EEG. It may come as a statement-based question. Is amplitude EEG used in HIE? Yes, it is used, but it is not used for diagnosing or managing a seizure activity. It is used for risk assessment and monitoring. Subtle brain abnormalities can be detected, but seizure activity is always better detected by the normal conventional EEG, which is used in any normal seizure patient. So these are the investigations that you will do in addition to the usual blood investigations like ABG, blood sugar, blood glucose, calcium, which are done in any emergency patient. Now finally we come to the management of HIE. Management comprises two parts. We have a supportive therapy. We have a new specific therapies. So supportive therapies, first of all, you will use IV fluids to the patient. Why IV fluid? Feeding cannot be started in HIE. When you give IV fluids, you should ensure that there is no hypotension. Hypotension, that is fall in BP, can compromise cerebral blood flow and exacerbate the brain injury. So ensure there is no hypotension. Normal maintenance fluids are used. When you are using IV dextrose when it is being given, remember that the target blood sugar or blood glucose in these children is between 70 to 100 milligram per deciliter. This is your potential MCQ, because both hypoglycemia and hyperglycemia are associated with increased injury to the brain. The second thing you will do is IV calcium gluconate in maintenance doses. chances of hypocalcemia are very frequent, and hypocalcemia can further irritate the hypoxic irritated neurons and result in severe seizures. So, IV calcium gluconate in maintenance doses is added in most of these individuals. Thirdly, for the case of seizures, the drug of choice is always phenobarbital. This is also your MCQ point already asked in the exam. AIMS entrance, it has already been asked. So, drug of choice for seizure in HIE, phenobarbital. New thing, AIMS, Nelson says there are certain group of children who do not respond to phenobarbital. In such patients, a second line drug for if phenobarbital is not effective is levetiracetam. So, if it is not effective, levetiracetam should be used, newly added in New Nelson. So, can be a potential MCQ. And there is no role of corticosteroids in the management of HIE. So, this is a old neat MCQ. All of the following have a role in the management except one of the option was dexamethasone, and that was the answer by exclusion. Now, what is the specific therapy? In specific therapies, we have a therapy which is called as selective neuronal cooling. Selective neuronal cooling is also called as therapeutic hypothermia. Studies have shown that if you decrease the brain temperature to 33.5 degrees Celsius and maintain it for around minimum 6 hours and up to 72 hours, it decreases the cerebral metabolic rate, it reduces oxygen-derived free radical formation and reduces the formation of glutamate. Glutamate is an excitatory amino acid which is involved in seizure activity. So, when you do this procedure, the long-term outcome is improved. That is called as selective neuronal cooling. So, what are the things that you should remember? How does it act? What is the principle? The principle is on decreasing the temperature, there will be decreased cerebral metabolism, which will lead to less free radical formation and less glutamate production. It produces overall better long-term outcome. So, how do we do it? What are the points that you should know? The temperature we used is around 33.5 degrees Celsius. It is done for minimum 6 hours, maximum up to 72 hours. And when should you start? It is started post resuscitation as soon as the child is stabilized. ऐसा नहीं कि अभी seizure आ रहा है and you are giving hypothermia. Let the seizure go away. Once you manage the child and shifted him to ICU or to the cot of the child, then you need to start with selective neuronal cooling. You can get a photograph based upon this. They will show you this photograph and ask what is being done. This is a child who is receiving selective neuronal cooling. It decreases the temperature. There are probes which are attached and it decreases the temperature in a controlled way only of the brain. So, this is a selective neuronal cooling which is being done in this child. This child might have undergone hypoxic ischemic damage, right? And potential MCQ, MCQ Pearl, new agent which is now useful for HIE patients. The new agent which has been found useful is high dose erythropoietin, that is EPO. High dose erythropoietin is used as an adjunct to selective neuronal cooling and it has been shown to improve the long-term outcome. However, more studies are needed before it can be used as it can be mentioned as a established therapy. But Nelson talks about it. It says early studies have produced very good results. So, it can be used. It is being used in some of the centers as an adjunctive therapy. Eventually, finally, we come to prognostic factors or outcome factors in HIE. So, poor prognosis will be seen if any of the following factor is present. So, poor prognostic factors include, first of all, HIE stage 3, it will have a poor outcome. Oligouria. If there is oligouria either in the first 36 hours or any time oligouria which lasts more than 24 hours. that has a poor outcome. If the umbilical artery blood pH is less than 6.7, severe acidosis, it has a poor outcome. If there is abnormal neurological findings, any abnormal neurological findings persisting or lasting for more than 7 to 10 days, it has a poor outcome. If there is lack of spontaneous activity or spontaneous breathing, that is respiratory effort, more than 20 minutes after birth, again it carries a poor outcome. If there are refractory seizures, that is difficult to control seizures, it has a poor outcome. And finally, any child showing a decerebrate posturing will always have a poor outcome. So these are the poor prognostic factors. They can be asked as a potential MCQ for your exam. So this finishes our detailed discussion of the topic hypoxic ischemic encephalopathy. Let us briefly discuss neonatal reflexes. Actually, the correct term should be neonatal and infantile reflexes, because some of these reflexes are not found in a newborn. They tend to appear after the neonatal period is over. But conventionally, all of them are included in the ambit of neonatal reflexes. So let us begin the discussion. First of all, we have the reflexes which are present since birth. So in a term child, they will all be present at birth. The first reflex that we shall be discussing is a reflex called as rooting reflex. Rooting reflex is a reflex in which when you stroke the cheek of the child on one side, the child will turn his head towards that side. Rooting reflex is nature's way of ensuring that the child is able to locate and attach to nipple. So rooting reflex can be elicited like this. You stroke the cheek of the child laterally, neck is turned towards that side. You do it like this, child turns his face towards that side. That is called as rooting reflex. If you get a video, if you get a visual where the child's lateral side of cheek or angle of mouth is being stroked and child is turning his head, that will be rooting reflex. Now, what are the points that you should remember? What is the normal time of appearance? Normally appears at around 32 weeks of gestation. So in a term child, it will be present at birth. Even in a preterm child beyond 32 weeks, it will be present at birth. What is the time of disappearance? It begins to disappear. It begins to disappear around, according to Nelson, it begins to disappear around 1 month of age and fully disappears, absent, by 3 months. So by 3 months of, these are postnatal ages after birth. So this is the first reflex that you need to remember, that is the rooting reflex. Let us move towards the next reflex. The next reflex is sucking reflex, also called as suck reflex. Sucking reflex is you stroke the inner side of the lower lip, or you put something in the mouth of the child starts producing a sucking movement. That kind of a sucking movement reflexly is called as sucking reflex. Often parents would come to pediatricians and saying, our child is always hungry. You ask them why, they say whenever we put our finger in the mouth of the child, he starts sucking. That does not mean the child is always hungry, it simply means it is a reflex. So we need to counsel the parents that there is a sucking reflex which is present. Sucking reflex obviously helps the child in sucking from the breast, and it is a nature's way of ensuring feeding of the child. So sucking reflex, it appears, the timing of appearance, it appears between 28 to 32 weeks. Most of the children we find it is 32 weeks where it is present. Some of the books give a range of 20 to 32 weeks. If you have to choose one, 32 week will be the better answer. And what is the time by which it disappears? It disappears by 3 months of age. Now there is a controversy here. There are two types of questions which can be asked to you in exam. One is sucking reflex. Sucking reflex appears earliest around 28 weeks of gestation, right? Sucking movement of the fetus can be seen in utero as early as 18 to 20 weeks. Sucking movement in a fetus is different from sucking reflex. Reflex is we doing something and child showing a response. In a fetus, sucking ability, sucking movement, spontaneous, that is not a reflex. That can be seen quite early, that is around 20 weeks of gestation. So please differentiate between sucking movement in utero and sucking reflex, which is elicited in an actually born child. So second reflex is sucking reflex. Let us move to the third reflex. The third reflex is palmar grasp reflex. Palmar grasp reflex. Now this is one reflex I often see students eliciting unknowingly when they join pediatrics in the first year. So your childhood dream was to take MD pediatrics, you got the rank, you joined a medical college, first day of the posting you will be posted in a nursery, you have nothing else to do, you will find a cute kid. What I find people doing is they will just put their finger in the hand of the child and the child will will curl his fingers around that. So they would take a selfie or they will take a snap of the child and put it on their social media. So unknowingly what they are doing is a palmar grasp reflex. What is a palmar grasp reflex? Palmar grasp reflex is a reflex in which if you stroke the mid palm of the child will curl his fingers and hold the object like this. It can be a finger, it can be an object. That is called as, it is not the child is voluntarily doing it, it's a reflex by nature. So palmar grasp reflex looks something like this. Which reflex is being done here? Palmar grasp reflex is being done here. So what are the points that you should remember? It appears between 28 to 32 weeks and disappears again by 3 months of age. Next reflex. The next reflex is a very interesting reflex and MCQ on this has been asked. The next reflex is asymmetric tonic neck reflex. Asymmetric tonic neck reflex, in short it is written as ATNR. ATNR is performed in a supine child. The child is lying on his back. In a lying child, if you suddenly turn the head towards one side, extension of upper and lower limb will occur on the same side and flexion will occur on the opposite side. That is called as asymmetric tonic neck reflex. So what is asymmetric tonic neck reflex? In a supine child, on turning head to one side, you will find that there is extension of the limbs, both upper and lower limbs, on the same side. If the neck has been turned to right, you will have extension of limbs on the right side, and flexion of the limbs will occur on the opposite side. So if I have to show you a picture, which reflex has been performed here? On turning head to one side, can you see that there is extension of limbs on the affected side and flexion of limbs on the other side? This is asymmetric tonic neck reflex. Since such a type of a posture is also attained in a sporting event called as fencing. You know, fencing is a sporting event where they wear white clothes and they have those thin swords with which they fight. When they have to begin the fight, they always do take a posture like this. So it is also called as, the alternative name of this reflex is fencing posture reflex. Many times MCQ may be repeated, but they will change the name. It is a common name, not a scientific name, but this reflex is also called as fencing posture reflex. So what are the things about this? It typically appears around 35 weeks of gestation. So it will be present in a normal term newborn and disappears around 5 months of age. Some books give a range of 5 to 6 months. If you have to choose one, 5 months will be a better answer. So this is your asymmetric tonic neck reflex. After this, we come to one of the most important reflexes in neonatal period, that is Moro's reflex. So let us talk about Moro's reflex. Moro's reflex is mediated by the vestibular apparatus, so it is also considered to be a vestibular reflex. Although in recent times there has been controversy whether it is truly a vestibular reflex or not, but traditionally we consider it to be a vestibular reflex. How do we elicit? What we do in Moro's reflex is we hold the child Look at this procedure. So, if you have understood, I'll explain again. You are holding the child. अब ये जो मैंने बोला ना, इसके बीच में यहाँ पर वो छोटा वीडियो आएगा जो मैंने डॉल पे रिकॉर्ड किया है. Okay. So, to summarize, you are holding a child, supporting his back. You put your other hand behind the child and suddenly release it. When the child suddenly falls backwards, there is extension of the neck. On sudden extension of the neck, you will find abduction of the limbs, extension of the limbs, flexion of adduction of the limbs, and then flexion of the limbs. This may or may not be associated with cry. This is called as Morose reflex. So, if they put up a picture like this and they ask which reflex is being performed, this is the initial part of the reflex and this is the second part of the reflex. Morose reflex is being done here. To summarize, for understanding purpose, remember, on sudden hyperextension or simply extension of the neck, 4 events tend to occur in quick succession. There is abduction of the limbs. The sequence always remains same. There is extension of the limbs. This is the first part of the reflex. Then there is adduction of the limbs. And finally, there is flexion of the limbs. Whenever there is extension of the limbs, it is also associated with opening of fingers. It is associated with opening of fingers. So, it is not considered separately. Basically, fingers are opening, so extension of the digits is also happening. And it is often associated with crying. But crying traditionally has not been considered a part of the Morose reflex. So, what are the points that you need to remember from entrance point of view? First of all, what is the time of appearance? There are many types of Morose reflex which you can see. See, you need to understand that the first component to appear is opening of the fingers. The opening of the fingers can be elicited as early as 28 weeks of gestation. Right? There is a term called as incomplete or immature Moro. Incomplete or immature Morose reflex is that which is present around 32 weeks of gestation, in which the abduction and extension component, that is the first component, is present, but the second component is not yet appeared. What is complete Moro or mature Moro? Complete or mature Moro appears around 36 to 37 weeks of gestation. So, it is present in a normal term individuals in which all the 4 components are present. So, you should know the difference. If they ask what is the first to appear, this appears, this is the appearance, and the first to appear is opening of fingers around 28 weeks. What is incomplete Moro? Only the first 2 components are present, that is present around 32 weeks. And what is complete Moro? 36 to 37 weeks, all the 4 components are present. What are the abnormalities that can be seen and which are asked in exams? Multiple MCQs have been asked based upon this. So, first of all, what is the time of disappearance? The time of disappearance, Nelson gives a range between 3 to 6 months. If you have to choose one, the better answer is 6 months. What is persistent Moro? Abnormally persistent Moro? It is said to be there if fails to disappear by 6 months of age, 6 months of postnatal age. And what if there is persistent Moro, what should you suspect? In persistent Moro, you should suspect frontal lobe damage. So, there is brain damage, that is why it is not disappearing. It is a primitive reflex, it should go away. What is the cause of exaggerated Moro or brisk Moro? Exaggerated and brisk are not exactly same, but in terms of Morose reflex, they are undergraduate level and postgraduate level, they are taken to be the same. Exaggerated Moro is seen in hypoxic ischemic encephalopathy stage 1, sometimes, not always. It can also be seen in hypoglycemia, which produces a jittery child. So exaggerated Moro can be seen in these two conditions. Absent Moro reflex will be seen in hypoxic ischemic encephalopathy stage 3, that is severe form, it is absent. Then Moro's reflex is transiently absent on the side on which child is grasping something. So there is a child, you try to do Moro, but the child is holding something using his palmar grasp reflex. On the affected side, Moro's reflex will not be present. So this is called as transient disappearance of Moro on the affected side. So Moro's reflex will be transiently absent if the child is grasping something. Then we have asymmetric Moro. Asymmetric means present only on one side, consistently not present on the other. Asymmetric Moro has been asked 2 times in AIIMS entrance exam. There are multiple causes. First of all, it can be seen in Erb's palsy. Second, it can be seen in fracture of the humerus. It can also be seen in fracture of the clavicle. It can be seen in shoulder dislocation, and it can be seen in hemiplegia. So these are the causes of asymmetric Moro. So we have discussed the details about Moro's reflex. Let us now discuss 2 miscellaneous reflexes. These reflexes are not very prominently mentioned in the textbooks you read in MBBS, but they are asked indeed in your entrance exam. Both of these reflexes are done in a prone position. So they are done in prone position. You can do them in a suspension also by picking the child from tummy, but more comfortably they are done by putting the child on his tummy. When you put the child on his tummy, there are 2 reflexes which can be performed. The first reflex is a reflex called as gallant reflex. Gallant reflex is also called as trunk incurvation reflex. What we do in trunk incurvation reflex is, in a lying down child, lateral to the midline, we stroke the child from top to bottom. You will find that pelvis and trunk curves on the same side, like this. So if you go from top to bottom, lateral to the midline of the spine, you will find that the trunk incurvates like this and the pelvis also moves like this. This is called as gallant reflex. So if you have to remember that stroking on the back lateral to the spine will cause same side incurvation of trunk and pelvis. That is called as gallant reflex. Gallant reflex is normally present in newborns, although it may be difficult to elicit in very young babies, but it is found to be present in most of the newborns at birth. It tends to disappear somewhere around 6 months. Different textbooks give a broad range ranging between 4 to 9 months. If they ask a range, the answer will be 4 to 9 months. If they ask a single value, it will be 6 months. More importantly, they can ask you as a visual or a video. This reflex, if the trunk is curving on the one side where it is being stroked, you call it as gallant reflex. Second reflex which is done in prone position is Perez reflex. In Perez reflex, again in a prone position, now you will not move laterally. You will move in the midline, but not from top to bottom, from bottom to top. So you will stroke the midline of the back from down to top. You will find on doing this, the child will have extension of the neck. There will be flexion of the upper limbs. Plus, there will be occasional crying by the child. So, I have to show you this picture, it will look something like this. Which reflex is being performed here? This is Perez reflex which is being performed here. And when you are going from top to bottom in the midline, as you can see, there is extension of the neck which is happening. There is flexion of this at the level of elbow which is happening, making the child sit up like this in a lying down position. It may or may not be associated with crying. The photograph is showing a smiling child, but crying is a variable element. Again, disappearance time, it will not be asked. The time of disappearance again in these patients is variable. But it ranges again between as early as 4 months to as late as 12 months. So, it is a variable thing, but it is not going to be asked in the exam. More importantly, you should remember it is done in prone position. This is how this reflex looks like, and this is how this reflex looks like. This is a very simplistic way, the most simple way I can explain. They are much more complicated when you try to do them on actual children. So, don't worry, you will be doing it if you take up MD Pediatrics. After talking about these reflexes, we move towards reflexes which are not present since birth. There are 3 reflexes which are not present since birth, and so they are more accurately called as infantile reflexes rather than neonatal reflexes. So, there are 3 reflexes that you need to remember which are not present since birth in a term child. The mnemonic for that is SPL. S stands for symmetric tonic neck reflex. P stands for parachute reflex, and L stands for Landau reflex. Let us discuss the 3 reflexes. First, we will be discussing about symmetric tonic neck reflex. Symmetric tonic neck reflex. Symmetric tonic neck reflex is also called as cat's reflex. This reflex is not present since birth. It usually appears around 4 to 6 months of postnatal life after birth and disappears around 8 to 12 months of age. Usually 10 months is the time we take for this. Why we call it as a cat's reflex? It is done in a child. First of all, you put the child on all 4 limbs. For all 4 limbs, it will not be possible to put a younger child. You put the child in prone position or support him by bringing him forward on his tummy. After you put like this, the child is firmly supporting himself. Usually around 5 to 6 months, the child is able to sit with support. If you suddenly extend the neck of the child, you will find that the upper limbs also become extended, whereas the lower limbs become flexed. Look at this posture. This is how a cat also sits, and so it is called as a cat's reflex. What is symmetric tonic neck reflex? How it is explained, how you will remember? On putting the child in face forward or quadruped position. Quadruped position is in which the child is on all 4 limbs being supported like this. So, on putting the child in face forward position, when you extend the neck of the child, there will be extension of the upper limbs, flexion of the lower limbs. Reverse will happen when you flex the neck of the child. There will be flexion of the upper limbs and extension of the lower limbs. So, how to remember it? Just try to imagine how a cat sits. If you are a cat, you will sit with like this. Your hands will be in the front, your neck will be extended, and your lower limbs will be flexed, just like this child is sitting. Since this is a posture a cat adopts, it is also called as a cat's reflex. These reflexes are very difficult to elicit in a normal child, and it is even more difficult, to remember them. So that is why these alternative names have been created, so you are able to remember that. All they will ask in the entrance is, first of all, the alternative name, time of appearance and disappearance. Thirdly, they will ask the visual of the reflex. So this is a visual which will tell you a symmetric tonic neck reflex is being performed. Asymmetric was lying in a prone position, turning head to one side. Symmetric reflex, putting the child in face forward or quadruped position. This quadruped position is something, again, which is more of a practical thing rather than a theoretical thing. Next, we move our attention to Landau reflex. Landau reflex is also called as flying Superman reflex. Alternative name. Flying Superman reflex, very simple. Any child above 3 months of age, you will suspend from his tummy like this, right? When you extend the neck of the child, you will find that the limbs also become extended. When you flex the neck of the child, the limbs also become flexed. so that a proper curvature is formed. This is called as Landau reflex. So if I have to show you a diagram, this is how Landau reflex will look like. Look at this picture. So on suspension of the child from holding from tummy, if you flex the neck, there will be flexion of limbs, all four limbs. And if you extend the neck, there will be extension of all four limbs. This looks like an appearance as if a Superman is flying. So because the limbs become like that on extension of the neck, you flexed, it becomes like this. You extend, it becomes like that. So it is called as flying Superman reflex. Landau reflex usually appears around 3 months of age and it disappears around 9 months of age. Both of them are postnatal ages, that is post-birth. Only when Landau reflex goes away, then the final reflex which we will be discussing, which comes into play, that is parachute reflex. What is parachute reflex? Just like you are doing Landau reflex, here you are not doing anything. You will just suspend the child like this. On suspension, automatically the limbs will undergo extension without the need for changing the position of the neck. So what is parachute reflex? It looks something like this. On putting the child on his tummy, that is abdomen, all four limbs, all these statements which I am writing in these reflexes, they are meant to be understood. So I'm not using technical words, because technical words, even if I write, you're not going to remember that. How to perform these reflexes and what these reflexes are, understanding is more important. So putting child on abdomen, all four limbs go into extension. In Landau, we were flexing extending the neck, then only they were extending. Here, they will just go into extension just like that. That is called as parachute reflex. Parachute reflex is something like this. Parachute reflex, it appears when your Landau reflex goes away. So time of appearance is 9 months. When does it disappear? It never disappears. It persists throughout life. So as I am writing and as you are listening to this video, parachute reflex is present in all of us. So when you go for bungee jumping, when you're wearing a parachute, you jump from some place, or when you're walking and suddenly you stumble, suddenly your limbs tend to go like this, like this. So this is your parachute reflex coming into play. So these are the important reflexes that you need to understand. More importantly, focus on the time of appearance, time of disappearance, and the visual which can be asked upon them.